Hello, welcome to Converging Dialogues. This is Xavier Bonilla, and on this episode I have Camilo Ortiz. He is a clinical psychologist and professor. In this episode, we talk about the differences between PhD and PsyD in the clinical psych world, and what that looks like and some of the history for it. We talk about the 3 waves of cognitive behavioral therapy, or CBT, and look at some of the efficacy and effectiveness of CBT for many disorders and symptoms. We also talk about the importance of theoretical case conceptualization over just using techniques alone. We give some examples, and then we talk about some of the aspects of therapeutic practice, including the need for appropriate use of techniques of exposure therapy by clinicians. And then we talk about disruptive behaviors, both just in a general sense, and then more clinically, and then somewhat diagnostically. We talk about the importance of training parents with good behavioral parenting skills and on some of the negative cycles that can happen. We talk a little bit about the controversy around disruptive mood dysregulation disorder, or DMDD, which was a added disorder in the DSM-5. And then we talk about his work with elimination disorders. And he gives some of the definitions and the treatments for them, and kind of how he's seen it in his clinical practice. And then we talk about the importance of encouraging children to have good independence as they grow and get older, and many other topics. Camilo is a great guy. He is very talented and, obviously very skilled and knowledgeable. And, he's great for the people he supervises and trains and teaches, and for clients as well. And so, it was a lot of fun talking to him for a couple hours that we did, and just kind of getting in, I think I say it in the episode, kind of like putting on a comfortable, or your favorite jacket. The clinical world is so comfortable for me. And so talking to people that are also in the clinical world is, just kind of feels like home base for me. So I always, always enjoy these conversations. So now I bring you Camilo Ortiz. I'm here with Camilo Ortiz. What's going on, man?
Hey, nice to see you.
Yeah, thanks for coming on. I appreciate it. We are doing this. You're my first person in the new year. So happy new year, all that. Start 21 with a bang. This will get released probably in, a month or so, but yeah, it's good to see you. Tell listeners what your background is, what your specialties, what your experience, what you do, and what you're currently working on.
So I'm a clinical psychologist and a professor, an associate professor at Long Island University. There's a couple of campuses, and we are the one that is physically on Long Island. It's called LIU Post, and we have a PsyD program. I know that you have a PsyD, right?
That's right.
Yeah. So it's a Doctor of Psychology program where I'm a co-director of clinical training. Traditionally, my research has been in parenting and disruptive behavior in little kids. But I'm also quite interested in anxiety disorders and exposure therapy as a treatment for anxiety. So I do some work there. And then I have this quirky interest in what we call elimination disorders. So this is kids who are having trouble peeing and pooping where they're supposed to. Mm-hmm. And there's a whole backstory about what got me interested in that. People usually want to know that. Mm-hmm. And I have a private practice not too far from campus that keeps me busy, where I see all kinds of clients.
Well, one of the things that people will sometimes tell me is, is it just me, or do psychologists, do they just always, they're just doing a bunch of shit? They never just have, I guess some do, but they always are teaching, they got a private practice, they do consulting, like they're just really busy people. And I think that's somewhat true, just kind of as it happens. So yeah, I have colleagues of mine that the same. It's like I'm doing this and this and this and this, and I part-time do this. And so I think it's a good thing though, right? Because we're using all the all the skills and education experience that we've took forever to get trained on. So
well, in some ways, it's a really fantastic degree because you don't really have to know what you want to do when you start it because so many opportunities open up. And when I started, I I had sort of a limited sense as to what clinical psychology was, and I thought I wanted to be a full-time therapist and probably a psychoanalyst because that's what I had seen in the movies. And I'm pretty behavioral, so my students all think that that's a really funny how I've become a cognitive behavioral researcher in many ways. Yeah. It's a good degree, but it does keep you busy. Just this morning, my mother called me and said, what are you doing on Sunday? And I said, working. And she still doesn't understand that I really don't take a day off. Too much fun stuff to do.
Yeah, it's one of those things where if you really love it, it's once you get the degree and everything, you're finished and all the hours and everything, you're finally able to do what you want to do. I mean, there's just so much of it when you're, is 10, 12, 15 years for some people, various degrees and all the hoops you got to jump through. It's like, well, when can I just actually do what I want to do? And so then when we finally do it, it's kind of like, oh, we're just doing a bunch of things. So I feel you. You also have the PsyD as well, or PhD?
No, I have a PhD. I got it at the University of Massachusetts Amherst.
Okay. Yeah. So you train PsyDs, or the program is a PsyD program. Is that correct?
Train PsyDs. Yeah, I actually do not teach undergraduates. At LIU, we have a strange system where we have two independent, really, psychology departments. One is just for the doctoral students, and then the other one is your traditional undergraduate and master's program.
I talked about this with a previous guest, maybe because it might be prudent to say it here. Sometimes people get somewhat confused or have somewhat of a certain, I guess you could say, approach or attitude about PsyD, PhD, and how do you, see the differences, if any, and what you think about it, since you have the PhD but you're training PsyDs? How do you see it?
Yeah, it's a good question. I think when the PsyD was developed, it was really meant to be quite different and meant to be for practitioners who were not going to be professors and not do much research. In practice these days, I don't think there's a big difference. Some of the best researchers I know have PsyDs, and a lot of our students end up doing some research as part of what they do once they leave. But overall, I'd say there's still more of a clinical focus. So in our program, for example, there's a dissertation, and that dissertation, in many ways, is really identical to a PhD dissertation. But there isn't a master's thesis that is a research project. Instead, they do a clinical project where they present a case in front of a panel of psychologists with a really extensive write-up and kind of defend what they did and talk about that. So that's one very specific way that we are more clinical.
Yeah, I think that that's kind of my read on it too, is that, there was this sort of internal, war kind of thing of like, PsyD, PhD. But I think now over, I don't know how long it's been. It's probably been 20, 30 years. I don't know, something like that. It's been one of those things where they really are synonymous in some ways. There are differences and distinctions. I mean, but it mostly just comes down to practitioner scientist, practitioner scholar model, with just two different types of models of how it's organized. But in practice, it's almost the same functions. You can PhD or PsyD, you can do psychological assessment, you can do psychotherapy, group, couples, family, individual, in different locations. I mean, there's really, no difference. I don't think at this point in
not
practical
really.
Application of what you could or couldn't do. So it's more of just an emphasis on a little bit on what you focus on. And so some people are like, well, PhDs are the scholars, and PsyDs are the practitioners, clinicians, and that's even not true either. So it is kind of really splitting hairs at this point.
That's right. Yeah, the PsyD used to be viewed, I think, as a lesser degree, but I really don't think that's the case anymore. I mean, when you look at, for example, the placement rates of our students on internship, they are higher than the typical PhD programs. So clearly, it's not hurting them in terms of prestige at that point.
Yeah. So you kind of alluded to it a little bit. You had said that you started out wanting to do therapy when you went and did your program, and then kind of behaviorism. You got sucked into that, and you just stayed there. And so now you're, well, maybe not behaviorism, traditionally, but
well, not too far from it.
Okay, yeah. So, well, I mean, we'll get into it, but I mean, if you're dealing with certain types of disruptive behaviors or elimination disorders, that would make sense. But yeah, just kind of where you sit. I guess we can start conceptually, and then I guess more specifically. So, yeah, just theoretically, and then in terms of interventions and practice, where do you kind of what universe are you in? What world are you inhabiting?
Yeah. That's a good question. Well, maybe some background would be useful.
Okay.
So,
yeah.
when we talk about cognitive behavioral therapy, we often think of three waves of it. So, the initial wave, that was Skinner and Watson, was really behavioral interventions, so exposure and systematic desensitization. And then that was really the only game in town for a couple of decades. And then Aaron Beck and Albert Ellis came along in the 60s and 70s, and they really popularized the importance of cognition or thinking. And so many cognitive behavioral interventions really shifted to understanding the way that people think and identifying what they used to call irrational thinking, and sort of trying to eradicate that with the thought that if you thought about things differently, it would improve your functioning and you would feel differently and you would behave differently. More recently, in the last 20 years or so, is what we call the third wave of CBT, which are mindfulness and acceptance-based approaches. And the two most popular are dialectical behavior therapy, which was developed to treat borderline personality disorder, but now is used on a whole range of different problems. And then ACT, or acceptance and commitment therapy. And so in terms of what I do, I really have kind of followed those three stages where I'm doing a lot of acceptance work these days. But at the root of it, I'm a behaviorist, and if I ever have a choice, I'm going to pick a behavioral intervention because I think they're more powerful. Just you can talk to someone about the logic of their thinking forever, and most people will know. For example, let's take an example of someone who's afraid to fly. They will know that planes don't crash that often, and they will know that most people sitting around them are not terrified. And there's not any evidence really that you can provide them where they're going to say, "Oh, you're right, no problem, I'll get on that plane." They need to experience that, and probably a whole bunch of times. And that's why behavioral interventions are really cognitive interventions, because if you experience something and things don't turn out the way you predicted, your cognitions will change in a much more fundamental and powerful way than talking about the logic behind your thinking.
Mm-hmm. Yeah, that's very nice the way you put it in terms of the three waves. I think just to follow up on that, Freud was the kind of the progenitor of all of modern psychotherapy in terms of making a system of how to do things. And 1900-ish, you can go back to William James, but really Freud was the man. And then there was a bunch of neo-Freudians after him, and then you started to have this I don't say split, but this divergence, and that's where behaviorism comes on the scene in the 40s, 50s, something like that, or late 50s. And then so it's funny because most behaviorists were trained as psychoanalysts, or they're Freudian,
all of the early ones,
because that's all that was there, and
including the two big ones,
right?
Albert
Skinner,
Ellis and Aaron Beck.
Or so Ellis or Beck is still alive, which is wild. I think he's 99 or 100. It's incredible.
He might even be a little older than that.
He's
but yeah.
Yes, he is.
And he's still doing cutting edge work.
Right. He
Amazing man.
still does. He's still on papers and still has trainees and stuff. It's wild. Yeah, but you're absolutely right. He did the more cognitive aspects because I think if I remember, I mean, you would know this obviously more than I would. Behaviorism was strictly focused on behavior, right? It was not a lot of this tinkering around in the psyche and the unconscious and all these strange things that we can't really measure and understand. It was,
Right.
well, what do I have in front of me? Or what are the behaviors in front of me? Well, that's what we need to change. Like,
yeah.
And so then all the way up to today, which rightly said is DBT, ACT is the big ones. So tell me, I guess, if let me just use a common example. If I come to you and I say, "Hey, I'm feeling depressed," or "I feel anxious," right? Something very common, kind of the what we would call a neurotic or high functioning or well managed person typically has a job, has a family, does things on the weekends, but just feels depressed or anxious. You know, why in your estimation do you see some form of cognitive behavioral therapy, whatever iteration is useful or helpful for somebody like that?
Well, I think the simple answer to that is that the research supports that it is.
Sure.
And
Right.
many well done randomized controlled trials of CBT showing it to be an effective treatment for all kinds of anxiety and depression. And by the way, there are a number of evidence based psychotherapies for those problems that are not CBT. And so
Hmm.
I'm not sort of orthodox about cognitive behavioral therapy. I use some other approaches if there's evidence behind them. So if we put that aside, there's also a sort of theoretical logic to the approach, and we can think about the three waves in working with somebody who's depressed. And so we know, for example, there's research suggesting that people who are depressed experience a lack of reinforcement in their lives, a change, so a reduction in the amount of reinforcement.
Hmm.
So if I were to work with someone in a first wave approach, really behavioral, we would do what we call behavioral activation, for example, and we would figure out where in their day are there gaps where they are not doing anything particularly pleasurable or where they feel a sense of accomplishment. And we would, pretty simply brainstorm some ways to include some activities to get them activated, because people who are depressed tend to stay at home, they tend to
Hmm.
reduce interactions with others, they tend to not do as many things that they used to find enjoyable. So really simply behaviorally, we would introduce some things into their day. If we were to take a second wave approach, we would look at their thinking
Hmm.
and say, we know that people who are depressed tend to have some types of unhelpful thinking. For example, they tend to think in black and white terms.
Hmm.
So if they're feeling lousy that day, then it's there's no gradation, so it's just awful and terrible.
Hmm.
And the alternative would be that they're feeling normal. And so that style of thinking is not helpful in getting better. And so we would identify that style, or we have about 10 or 12 different styles of thinking that
Hmm.
we've identified, and help them to notice when that happens and then to come up with a sort of rational response to that.
Hmm.
And the third wave approach, we might say, um, let's not really debate your thoughts, because that is tiring and takes a lot of energy. And in some ways, you kind of are already losing if you're debating these thoughts, because it's pulling you away from value driven behavior, the things that are important to you. So, can we work on acknowledging, accepting that in a typical day, a human being will have 10,000 different thoughts. Some of them will be negative, some of them will be positive. And if we can get good at noticing thoughts and letting them be there without pushing them away, without avoiding them, then we might not actually even have to change your thoughts. And that can also lift mood, the acceptance that thoughts are not always supposed to be positive, and our brains are threat detectors, and they look for problems. And that's really made a big change in the way that I practice. I pretty much was brought up in that second way, where we have to identify irrational thoughts and refute them. And I started seeing that there's some downsides to that approach.
Mm-hmm. Yeah. Do you see, I guess, conceptually, or how you theoretically conceptualize clients or just folks in general from a cognitive or behavioral mindset, or not at all? Is it more of just a kind of an eclectic or integrative approach that you use?
No, I conceptualize most kinds of psychopathology as having a behavioral component and a cognitive component.
Mm-hmm.
I was trained in a program that had a pretty strong psychoanalytic component to it as well. And so I know a little bit more than I think maybe your typical cognitive behavioral therapist about some other approaches. And at LIU Post, we actually have a dual theoretical model where we train our students in both approaches. So once they leave, they're actually supposed to be quite skilled at both approaches. So we have 4 psychoanalytic or psychodynamic professors, 4 CBT professors. And so we get into it and we talk about the differences a lot.
Yeah, no, that's great. I bring that up because I think that's super important for people to understand with, I'll say psychologists, maybe other folks do this as well, but psychologists in particular, is the so in terms of doing psychotherapy, there's people go to traditional talk therapy for various reasons. Like I said, they feel anxious, they feel depressed, they feel they have a bad relationship, they have a loss, they a whole myriad of issues, and they go to someone that is trained to do these things and an expert in these things, and can help them not feel like shit. I don't want to feel this way, doc, help me out. And meds are cool, but I don't most people don't like taking meds, and or if they do, they don't want to take them forever, and so they want to find ways to figure it out. And I think it's the thing that I tell trainees, and the thing that I tell students that I teach, is you have to have a type of philosophy, or you have to have a conceptualization of the person. Because if you are just going and just giving a bunch of techniques, if you're just, for example, a traditional cognitive behavioral technique is a thought record, right? Which is this kind of, how do we challenge the negative thoughts? The various kind of the classifications you were talking about, cognitive distortions. And so we don't have those negative thoughts, and they don't intrude in our lives as much. And so if we stop the thoughts, we can, stop having as, horrible interactions. It's a very simplistic reductionist way of saying it. But so many therapists will just throw an intervention at somebody with nothing tethered to it, nothing connected to it. And so then a client goes to therapy and they're like, well, what the fuck is this? I was like, I came here to get something done. And, I did a couple techniques a few times, but I still feel terrible. Like, what is this? And that's not to say that some of those things can't be helpful, or that everyone needs that type of training. But I do think that it behooves clinicians in general, and definitely psychologists, to have a theoretical framework. So there has to be a certain approach or a certain way. I kind of see it as like a bookshelf, right? Or it's a framing of how you understand a person and how they work. And there's a bunch, but there's at least 3 or 4 major ones. So similar to what you were saying, in my program, we did 3, which was just a lot of work. It was a lot of work. It was psychodynamic, or kind of the analytic tradition of Freud. It was cognitive behavioral therapy, and then it was family systems. I teach at a school now which has 4, which is those 3 plus existential humanistic, which is one of the courses I teach. And so all of that is saying is, here's a theory, and then here's the data and the science behind it, so we understand how to use some of these things. And then here are the interventions that we can use, right? So I think when certain clinicians will just give interventions, they're missing two big prior antecedents to that, right? They're missing sometimes the research and they're missing sometimes the theory. And so you're basically just, throwing things around with, it's like throwing spaghetti on the wall and hoping it sticks. It's like, well, I don't know why this doesn't work. And the whole point of interventions for clients is there's a purpose, there's a compass, there's some type of blueprint of like, okay, I'm understanding this person, I'm hearing what they're saying. Here's, I think, a direction we should go. This is an intervention that could help alleviate this, or it could really resolve some of these things, or what have you. And so when you and I are talking about this, that's what I think the importance of this is. How does all that sound?
I'm so glad you brought this up, and when my students listen to this, they're gonna know exactly what I'm going to say, because I talk about this a lot. So, when I was trained in graduate school, it was kind of the approach that you described, where they taught us techniques, and we sort of had to like look at someone's symptoms and then think through what technique matches those symptoms. That's what we sometimes call the topographical approach to psychotherapy, where you sort of from a map perspective, you're looking down and the peaks are symptoms, and you're treating those symptoms. And that can lead to what you describe, which is kind of like a shotgun approach to therapy, where you're hoping what you do kind of hits something. And our students now train in a case conceptualization approach, where they have to understand a theoretical explanation for symptoms. And that is sort of like underneath the topography, what's going on there. And we call those mechanisms. So, for example, you might have someone who is depressed and anxious, and those might seem to a therapist to be two different things, two peaks, two mountains. But there might be some common mechanisms that are causing both of those problems. So, for example, a client might be avoidant of emotion, and that can lead to feeling anxious and depressed. A client, as we talked about before, might be having a reduction in positive reinforcement in their life. And that's also a mechanism that can be causing both problems. So what I teach my students to do is to write out what we call a case conceptualization, or a case formulation, that describes all of the problems a client has, and also hypothesizes some mechanisms. And the mechanisms are what we treat. And if you do that efficiently, you can hit multiple problems at once. And you also have a very clear theoretical reason for an intervention, as opposed to it kind of like matches what the symptom looks like, which is not a great way to do psychotherapy. And not many clinicians really do it that way. And I have talked to many practicing clinicians, and I'll say kind of what you said, which is like, what theory guides your case formulations, your case conceptualizations? And they don't often know what I'm talking about, which to me suggests that they are using the symptom matching approach. And another problem with that is, all of your listeners may not know this, but many psychologists use treatment manuals, and they kind of teach you in session 1, this is what you do. In session 2, this is what you do for each particular problem. And we've had quite a proliferation of treatment manuals. When I was in graduate school, I have one on my shelf that there was one, and it had about 10 different disorders in it. And it was a great start. And now there are probably thousands of treatment manuals, because as we understand problems more, we start subdividing them into other problems. And that is not a sustainable approach, because you as a clinician cannot read every treatment manual that exists. Whereas if you understand some common mechanisms and how to treat them, then you only need to really know how to treat about 4 or 5 things, and you can treat almost anything. And so, avoidance is a mechanism that is maybe the biggest one across a lot of different disorders. And if you know how to treat avoidance, it doesn't matter what you call it, whether you call it OCD or you call it generalized anxiety. If a person is avoiding things, that tells you what, as a clinician, to do a lot of the time. And you don't have to worry about diagnosis as much, or counting symptoms, or what things is called. things are called. You focus on the underlying mechanism, and that can make you a much stronger and more efficient clinician.
Yeah, I agree wholeheartedly. It makes me very happy to hear all this. It's it's I'm kind of like you. I not to pick on or any clinicians, but sometimes it's just not their training or less interest or what have you. But um, eh, to me, this is something that for psychologists, like this stuff is really important to me. Like it's really important not only for myself or my colleagues or the field, but it's also I think for clients in general, because it's I don't know about you, but I spend probably a healthy percentage of my time dispelling bullshit with clients when they come in. And it's like, no, that's not true. Oh God, please don't tell me the name of that person. I don't want to know. Like, and again, I'm not trying to pick on people, but there is just a lot of inaccurate material out there. And it is frustrating. It is frustrating. And so again, I don't what you're not saying this and I'm not saying this. Not that you or I have the codified answer to X, but it's more of, do you have a framework of understanding these things? Sometimes, I think it's one of those things where you brought the treatment manuals. Again, you can have a self-help book, you can have a treatment manual, you can have a workbook, you can have these things, and there are, I'll say with treatment manuals, there is something about having manualized kind of treatment that is important, I think helpful. But y- y- too often it becomes this kind of cookbook thing, right? Session one, do these three things, session two, and that's not, that's not therapy to me. Um, and that might be a component or an element. Another way of saying this is, for example, so I was obviously trained in CBT, but I don't conceptualize folks that way. I'm more psychodynamic, so we can fight about that if you want, but um, but it doesn't really matter. I have a conceptualization. I have a way of understanding people. It's a developmental model. Okay, you have a way of conceptualizing people. It's a behavioral model. Okay, I can use cognitive or behavioral techniques and still conceptualize people the same way, and vice versa for you and for anybody that's doing that. And there's this kind of rigidity that some people have with these these kind of camps that they fight about in grad school or in psychology of you're this or this or this, and it doesn't they're not in opposition. It's just a different way. It's just what makes sense to you as a person of understanding someone. um I, and I tend to be a little more abstract, so it's not surprising that elements of existential humanistic but then also psychodynamic make sense to me. For other people that are um, what you call more directive or maybe more concrete, of course behavioral cognitive stuff would make more sense. I mean, it's just
Well, let me
it's a
push
lens.
back on that a little bit.
Go
So
ahead, go ahead.
we get into this a lot in our doctoral program, where our psychodynamic colleagues will say things like, "This is a very complex person, and so they're going to need psychodynamic therapy because cognitive behavioral therapy is too superficial for them, and it's only gonna treat the symptoms and not the underlying
Mhm,
causes." And I vehemently disagree with that.
sure.
I think cognitive behavioral therapy can be just as deep and creative and life changing as some of the other approaches. Um, Back to your earlier point. Now, when we examine what causes variability in treatment outcomes, why do some people get better? Why do some people not get better? The modality of the treatment, so cognitive behavioral versus existential versus psychodynamic, makes up a tiny sliver of that. Yeah. It actually is not for many problems particularly important. What is more important are what we call these common factors. So,
Yeah, yeah,
how, the therapist skill, the level of empathy, that sort of thing.
right.
Just the research shows that that swamps the theoretical orientation.
Hmm.
Now, having said that, for some problems, it does make a really big difference, and we will talk about things like elimination disorders or disruptive behavior, where there is a clear difference. And the gold standard for those two areas would be behavioral and cognitive behavioral approaches. But for more of your sort of run-of-the-mill unhappiness, anxiety, that sort of thing, it's not particularly important in most cases. What is the theoretical orientation of your therapist? But what I do think is important is what you said, is that they have some model to understand you as a person. And if they see you as a bunch of symptoms, and that's what they're going to try to play whack-a-mole with your symptoms, I don't find that to be effective therapy.
Yeah, and I agree. Kind of as a response to some of the things you said, I would agree. I think I have a good friend of mine. She was trained in her master's program, and then we went to school together. She at the doctorate level, she did hardcore like CBT. I mean, theoretically, research. She did some actual empirical research, and CBT is very deep, actually, theoretically, right? If you start understanding core beliefs, intermediary beliefs, compensatory, all of those issues, the model is very good. It's a very deep model. So yes, I would not make that claim that it's superficial, but I would say there is. It's a point of emphasis, I guess, right? And I don't think it's better or worse. It's just because I don't think every client is ready for that, or they don't want to do that. But
that's true.
Psychodynamic work has an emphasis on the past and on primary relationships and many things in early development as kind of charting the course for a person. And so they will spend more time there than folks that do strict CBT. Although, when you're talking about core beliefs, you do have to visit the past and you do have to explore
that. Those are typically formed in childhood, yes.
Right. But then it just becomes really a point of emphasis, right? So, but yes, I would agree with you on that. And absolutely the common factors, the overwhelmingly so, I don't have the numbers in front of me, but I know it's very high. I think it's probably over 70% is the therapeutic relationship is therapy, right? That is the key factor, right? That is the central factor. And that goes down from, right, empathy, experience, expertise, how you sit in a room with somebody, and I think that's really important. I think the other piece of things so I would absolutely acknowledge this, and I have said this to many people, is if I get someone that comes and sees me with social anxiety or a very specific phobia, if I feel like it's too much beyond my training, I would refer out. But we understand the gold standard for that stuff. I'm not going to be doing Freudian analysis with someone that has a specific phobia. Right. And the same thing with some of the behavioral stuff as well. When I worked inpatient for 4 or 5 years, and there was a lot of behaviorism, like old school traditional, behaviorism, creating these what do we call them? These huge behavioral intervention plans, and it was this 3 times per day, whatever, per week. It was very, very charted out, very, very systemized, but that was what was necessary in that environment for that population. So there's definitely some gold standards of certain challenges or issues and or disorders, if you want to put it that way, that certain therapies or techniques or interventions have shown they just have empirically supported treatment for that. And so to do anything outside of that would probably be, I wouldn't say unethical, but not good practice, I would say. My personal opinion.
I agree with that. Yeah.
So let's jump into that then. So tell us about disruptive behaviors, and then we can get into elimination stuff. But unless there was something else you wanted to say about this one piece.
Oh, I mean, maybe this is for later, but I do think that many therapists do not practice in ways that are evidence informed or evidence based, and particularly in the area of exposure therapy, which is such a powerful intervention. It's not often done, and the research is pretty shocking on it. So when you look at the treatment of people with PTSD, for example, there are a couple of really well documented types of interventions. One is an exposure based intervention, and then what we call cognitive processing therapy. And the vast majority of clinicians who treat people with PTSD do not use either of those two approaches. And we can speculate about the reasons why, but it's incredibly frustrating to see that we have effective treatments and they are not used. And even when they're used, they are often not used well. So exposure therapy is just something I think about a lot. When it is used, it is typically fairly mild and inert. And we know that the type of exposure that is really helpful is when there is surprise from the client's perspective. We get that change in cognitions. So for example, if you have a bird phobia, looking at some pictures on the internet of a bird is probably not going to do much to change your cognitions about birds. You're not going to get what we call that corrective learning. But if you go to an aviary and they let you inside and 50 birds land on you, that's going to make a really big change in those cognitions. Now, obviously, you don't start with that step because nobody would do that. But most clinicians don't really think about, these really strong versions of exposure therapy, and they, for lots of reasons, either because they're anxious themselves or they're worried about liability, or they think people will pass out. There's lots of barriers to therapists using exposure therapy. This is something I study, but it ends up causing fairly mild and inert treatments that don't end up working very well. So a lot to say about that, but yeah.
Yeah, no, I that's really, really, I'm glad you said that because that's really important. Exposure therapy is not something I'm trained in, so I don't do it. But the little I know is I know it usually has to be kind of the old school behaviorism stuff is very graduated, prolonged types of exposure. So you start very small, correct, and then you gradually build up to something where
you don't have to start small.
You don't have to. Okay.
Yeah. Most people do that because they think clients won't start medium or big, but that's not always the case. Sometimes clients are willing to. And one of the drawbacks of starting small is it can give the client the impression that we have to be very careful because this is dangerous and we have to slowly go up the ladder. And when I've had patients where we put all the exposure exercises into a hat and they randomly pick one, and it could be the top of the ladder. It could be the scariest thing.
We're going to cross that bridge today.
Okay. Yeah, right. But obviously you need sort of a very particular kind of a person who's willing to do that. And I wouldn't do that as the first time we do exposure. I usually do start with one very simple one so they understand the process. And then I say, how quickly do you want to go up this ladder? And then, it depends on the person, but sometimes we go up really quickly.
Yeah, that's nice.
I had a client a couple of weeks ago who has OCD and the sort of the typical contamination OCD. And very quickly, he was sticking his hands in toilets and rubbing them on his pillows and touching poop and rubbing that on his pillow and going to sleep like that. Now, he was someone who, to his credit, was incredibly brave and willing to move up really quickly. And his symptoms got better very quickly when he was able to do these sorts of exposures. But I understand that not everybody's going to be able to do that. There are one-day treatments for things like panic disorder, and you spend all day doing exposures, highly, highly effective. but not often used.
There's maybe we can come back to it, but there's, I think, I'm hesitant to say this. So this is all within the clinical world. I There's a way, I think, in which you can take some of the themes of this and maybe somewhat apply it, I think, in society in general. So I think maybe you think differently about this, but I think that the biggest treatment for uh, trauma or certain types of anxiety is exposure. Now, it's not for everybody. You have to be very careful and very mindful of each individual person. But the point is not to avoid it or to never deal with it or to not talk about it. The point is exposure at the individual level. So obviously, you're not doing this necessarily with groups or mass amounts of people, but I do think that in society at large, we get the opposite narratives that are stated about things, and I think that's problematic. But maybe we can come back to that.
Well, I'll just quickly say that the phrase "Are you comfortable with that?" is like nails on a chalkboard to me, because all of the clinical work I do really is making people uncomfortable.
Yes, yeah.
And I see the benefits of being able to tolerate discomfort every day.
Right.
So this societal goal we have of comfort, I think, is in some ways destructive. And yeah.
And it's strange too, because again, I mean, I've had those experiences as well. Maybe not as much as you have, because you're dealing with this very specifically clinically. But you obviously see that overwhelmingly people get better. If they didn't, then we wouldn't do it. This wouldn't be effective treatment. And you have different types of people that are getting better with different types of issues. And we shouldn't be so, I think, arrogant or about understanding or knowing what people can and can't handle. I think we have to try and let them see what they can handle. They might be surprised at themselves. And of course, right person, right setting, all that stuff. But yeah.
But evolution has made us remarkably resilient. We, especially children, which is where I see this drive for comfort to be particularly damaging. But we can handle a lot. And what I suggest to people outside of the clinical setting is to microdose discomfort. And I try to do it every day. And it's not hard to find opportunity to do that. So, as an example, this is something I do myself, and I suggest to people, which is, how a lot of people drive around for half an hour trying to get a parking spot that is as close to the front of a store as possible when it's cold.
Yeah.
Park a block away and notice the discomfort of the cold on your skin. And if you do that enough, then you start to notice that discomfort in other areas is not so bad. And that can be kind of life-changing if you actually look for discomfort in your life, little micro doses that you can control.
Yeah, no, I absolutely agree. I think that's the microdosing idea of it is really helpful, I think, because I think if you don't want to be a sadomasochist, right? Be like, I just want pain all the time. But if you're able to say like, hey, maybe it's fine if I'm able to, right, I park all the way at the far side of the parking lot, and and that's okay. And yeah, I think that's really important for people to get comfortable with things, because then when things do happen organically, quote unquote, it's less hitting you over the head with a 2x4. It's like, okay, like, yeah, this is going to happen. How can I deal with this? But still be mindful that people have different experiences, and they come from different places, and there are different spots in their life. But I think that should be at least the aspirational goal. So,
yeah. Another little activity I do with clients is to just have them sit there and notice the first itch that they feel, and it doesn't take long. And observe that itch and observe your desire to want to scratch it, and let it be there. Make room for it. And interestingly, for a lot of people, this is such a bizarre concept that you don't have to immediately feel better when you feel discomfort. You can actually almost kind of like thank your brain for noticing discomfort without trying to make it go away.
Yeah, I mean, this is you're bringing in the I can hear the mindfulness stuff coming out. You know, the meditative mindfulness stuff, which is great. I'm a big proponent of that as well. So I fully agree.
All right, so we talk about disruptive behavior.
Yeah. So tell me about that. Just maybe briefly give me the overview of how you got into it, why, and some, you know, and then we can explain kind of what it is and how it looks and all that stuff.
Yeah. Well, the easy answer is that my advisor in graduate school was a parenting guy, and I really liked him, and I wanted to work with him, and so that meant that I was going to work on parenting. But I also, even at that stage of applying to graduate programs where I didn't know much about the field, I did have a sense that our field spent a huge amount of resources on the sickest of people and people with the most severe problems, and I had a sense that there was not enough prevention work going on, and so I thought, well, what would be like the best way to prevent problems from happening? Could it be to train parents to deal with them at an early age, so that they wouldn't even need a therapist? And that germinated into really the career that I have, which is that my goal for most sessions around problems of disruptive behavior is to make parents the therapists, to teach them to, you know, open up the curtains and show them everything,
all the tricks,
but also what we discussed before, which is to give them a theoretical understanding of why it is that kids misbehave. And there are very good reasons, very logical reasons. And if they can understand that structure, then for any new misbehavior that happens, they can go back to their understanding of their general conceptualization and say, now let me think about this. This looks different to me, but might it serve the same function as some other misbehavior that I dealt with? If so, can I use some of the same tools? And they can often do an amazing job. They don't need a psychologist to help them. They can do a great job. And so I thought that would be a really good use of our resources as a field. And I very selfishly wanted something that would help me in my life, and I wanted to have kids, and I have two, and you can maybe interview them to see what they think about having a dad as a behavioral psychologist who specializes in parenting. But I think they're doing okay.
Yeah, I get some of that too, where you know, sometimes it'll be very interesting when my daughter will come to me. She's 13, she'll be 14 this year, and at every point she'll say, you know, my friends' parents, they don't do this. They don't say this. Why not? And it's just so normal, some things, you know, and it's like, yeah, well, you know, everybody's different. And so I am aware that she's anytime being raised by a psychologist or anybody in the mental health field, that I always wonder how they turn out when they get older. So hopefully for the best, right? But she's lovely. She's a great kid. So
That's great to hear. I have a very vivid memory of bringing I think she was 5 years old at the time, my daughter into my behavior therapy course to give her perspective on timeout and what it was like to be put in the timeout, because I wanted to give both sides of the story. And
negative punishment, right? Isn't that what it is? Right? Is that the term?
It's interesting because
negative reinforcement. I can't remember.
There are multiple ways of thinking about timeout, and it's not exactly clear which is the correct way. It could be viewed as an extinction approach and not necessarily a punishment approach, but that's probably beyond
what that's most very people technical.
Are interested.
Okay, so what do you do with mostly, I guess? So you're doing this in terms of clinical practice, or both in also teaching in academia, or both, or?
And research. Yeah,
and research. Okay,
it's the main thing that I do is to understand disruptive behavior in children and how to prevent it and how to treat it. And it's one of those things that there is no child who doesn't have disruptive behavior. So it is incredibly useful, I think, to understand it, even if your kid is in the totally normal range. And we know that for young kids, preschool age kids, they do not comply with between 20 and 40% of parental commands. So super common for kids to be non-compliant. Yeah.
Yeah. So I'm curious about this. So tell us, as much as you know, how do we define disruptive behaviors in a general broad sense, but then also how do we distinguish that from a clinical sense? And what does that look like?
Yeah. Well, it's a question that applies to most problems because everything that we see in practice does exist in a non-clinical range. And so we really think about disruption with the functioning of somebody. So if for whatever problem, I often get this question is how do we know whether to treat somebody? And what I'll usually do with any client is say, let's think about how this problem is disrupting your life and whether it is or not. And sometimes we'll figure out that it's not very disruptive and it's not worth it to try to fix it. So if you have a phobia of purple dogs, probably not worth 20 hours of your life of pretty extreme discomfort to do something about that. With kids, so there are various definitions of noncompliance, and there are different kinds of noncompliance. And any parent will immediately know that kids don't always say, F you, mom, I'm not doing that. It's far more common for them to tune you out and pretend like they didn't hear you. And we consider that what we call passive noncompliance. So the very basic definition of noncompliance is a child refusing to do something that they've been told to do. And when that starts interfering with functioning in relationships, then we think about doing something about it. And so what do we know about it? We know that working with parents is almost always more effective than working directly with children. And I get at least one call a week to my private practice with someone who says, my kid's not listening and I want you to see him in therapy. And sometimes these kids are 3 years old. And I have to have the same conversation. No evidence that would do anything. And if we think about it, I often can't get adults to take something we did in session and apply it 4 days later when they're dysregulated. So a 3-year-old, I'm going to tell them what to do when they're mad, and then they're supposed to remember that and do it at home days later. That's just not ever going to happen. And it's a pretty bizarre, maybe I want to blame psychoanalysis for this, holdover of I don't know where it came from, but this idea that you see little kids in therapy really does not have empirical support for most problems. So that tells us we work with parents.
Under age 5 is really, to me, not really conducive. Personally, I don't see kids.
I double that number.
Well, I think you could maybe 7, 8 for sure, but yeah, I would agree that anything under 5 is, they haven't developed enough. There's not even brain development as much as they need to. There's just too many things still forming. And, people are like, we have a, 2 or 3 or 4-year-old. I'm like, what the hell am I going to do with a 3-year-old? What am I going to do? Like, that's, even if you're doing, there are some people that do like pediatric stuff, but again, it's just not, I don't know. But yeah, so I'm with you on that at the, maybe we'll fight about which age, but definitely we can agree under 5, probably not, really, really helpful. And I don't think the literature is there on it. So
it's not. So if we decide that we're going to work with a parent who has a kid with disruptive behavior, then the question is, so what do we do? And the first step, as I mentioned before, is to help a parent understand the causes of misbehavior. And they're all reasonable, usually. It makes a lot of sense for kids to misbehave. And you get a rare parent who just has sort of incorrect developmental ideas about the amount of misbehavior that should be happening. But putting that aside, it's still really frustrating, and parents are pulling their hair out. But if you at least understand the causes, then that can make you a little more, or let's say a little less judgmental and angry at your kid, which is an important first step. And then there are certainly techniques that you would use. Should I get into, would it be helpful to think about what happens between parents and children that actually inadvertently reinforces misbehavior?
Sure.
Would that be useful?
Yeah.
Okay.
Yeah.
So our best understanding is what we call the coercive cycle. And this was developed by a guy named Jerry Patterson at the Oregon Social Learning Center in the 60s. And it's a really elegant model to help us understand, why it is that interactions between parents and kids get angrier during the interaction, and then over time, they get more coercive and escalate and get angrier over time. And it's a beautiful description of how this happens. It's sort of this dance between the parent and child where neither person knows that they're dancing. And they are both contributing to the escalation of the interaction without wanting it to escalate and without really needing it to escalate. So if we take the typical example, a mom walks by her teenager's bedroom and sees that it's a mess and says, Joey, can you please clean up your room? And he's on his video game and he just ignores her. So she goes, Joey, can you please clean up your room? And again, ignores her, either consciously or just has learned to tune her out. And so this repetition can be 3 to 7 times, can be 20 times. And typically it gets louder and louder and louder, more angry. Then parents typically go to threats. Joey, I told you a million times, if you don't clean up your room, I'm going to take everything that's on the floor and throw it in the garbage. And those threats can get bigger and louder and escalate. And sometimes those threats work, or even earlier on in the chain, a louder command can work. So what happens when escalation pays off? Well, from a parent's perspective, it then reinforces escalation. And the next time you walk by his room, you might not say nicely the first time, Joey, can you please clean up your room? You might jump to the threat, or at least louder. So now your behavior is being reinforced to escalate. If after the threat, he still says, fuck you, mom, I'm not cleaning up my room, you can't make me. The mom might say, you know what, live like a pig, I don't care. And they walk away. So what is now being reinforced? Well, the non-compliance is being reinforced because the parent withdraws the command, right? So now the child, either consciously or unconsciously, learns that escalation pays off. Or maybe the parent gets really violent and uses physical means, or does something like, I've had parents take a PS4 and throw it out a window. And that certainly will get compliance from a child. So what we see is compliance that is reasonable is not reinforced, but escalation and anger and disruption is inadvertently reinforced. And so then this sort of over time gets worse and worse and worse. And if you can understand that each person is escalating the wrong behavior in the other person, now you have a shot to do something about it. But if you don't understand the model, just like we talked about earlier, the throwing techniques at it is not going to be usually very helpful.
No, that's great. Yeah, that's great. How I after you said it, I remembered I had somewhere I had learned about the Patterson model briefly, but so I'm loosely familiar with it. And how do you find that it is effective? I guess in the work that you do or whatever, is it mostly effective, or just some people just really just don't get it, or what's your kind of pulse on it?
Yeah. So as I've put on years on my career, I've had two thoughts about this. One is that the power of genes and temperament gets clearer to me the more work that I do in this field, where I used to think if we just change parenting behavior, we can fix anybody. But because I used to think that the causality direction was parenting to child behavior. And now it is very clear to me that It is at least bidirectional, and maybe even child behavior pulls a certain kind of parenting much more than the other way around. And anyone who has multiple kids will say, duh, you don't need a PhD to know this. I am a different person with child one than I am with child two. Sure, I didn't learn new skills, but child one makes me crazy and makes me be a really bad parent, and child two makes me be the best version of me. So the research shows that about 2/3 of parents who undergo what we call behavioral parent training, BPT, find significant improvements in their child's behavior. And the typical course of BPT is anywhere between 8 and 20 sessions. And there are a bunch of different variations of it, but they all have the same fundamental skills. So for young kids, we teach how to reinforce good behavior. And we typically do that first before we get into discipline, because by the time someone comes in to see a psychologist, they're pretty pissed at their kids. And if their kids do something well, the last thing they feel like doing is praising that. So we have to radically change that imbalance as the first step. We also, and this has become a bigger part of what I do, which is to radically reduce the number of commands parents make. So there is no chance of an escalation if no command is even made in the first place. And parents often make tons of unnecessary commands. I have parents come into my clinic at Long Island University, and I sit behind a one-way mirror, and I have one of these like little league balls and strike clickers, and all I do is I count commands. And in 30 minutes, I have often counted 100 commands. So if you're a kid, if you're a 4-year-old and you're told to do 100 different things in 30 minutes, A, that's impossible. B, how do you grade like what's important? If there's so many of them.
Again, especially if you have a brain that isn't developed.
Yeah. Right.
You just don't have your prefrontal cortex fully online. You don't have your Wernicke-Broca's areas for language online. Like, it just is like comprehension wise. It's like, this is so much of the brain that's not even developed yet.
Yeah. So that may be the most important skill I teach, which is I want you to go home this week and I want you to reduce commands by at least 50%. And let's pick one in particular that you're not going to make this week. And it's typically something about being cold, getting back to discomfort, put on that coat, or about eating, the speed of eating, the amount of eating.
What you're eating.
Or about posture or something like that. If we get rid of those, parents often come back and say, wow, I had a really good week. I don't really know why. I don't know, it must have been the Ritalin he's on or something. And it's often just because you had many fewer opportunities for this coercive interchange that we discussed before, because you didn't make that command that wasn't necessary.
What happens when I've seen this happen the few times? So occasionally I'll do work with adolescents. And sometimes I'll get this. So you're absolutely, part of the reason I don't work with kids and adolescents mostly is because you just got to deal with the parents. And I just don't like hitting my head against. I mean, I do couples work, which is already, I love couples work, but it's also challenging.
See, I find that much more difficult. So that's interesting.
But parenting, though, is just like hitting my head against a brick wall. But it's just one of those things where it's like, you get a 15-year-old or 15, 16, and it's like, okay, fix him. It's like, well, again, you can't expect miracles if for 15 years they have all these patterns of like you got to admit or acknowledge that you weren't parent of the year most of those years, and you got to change a lot of your stuff. And the couple years you have left with your kid under your roof, but don't expect miracles. I mean, this is 15, 16 years. They're full adults, like. And that stuff just really frustrates me because I'm just like, what do you expect? Like,
well, this is the beauty of that coercive cycle, that if someone comes in, there's no judgment coming from me, because I'll show them you were inadvertently reinforced to be angry and yell, because that's when he would listen. So I feel I feel for you that you were sort of pulled into this coercive trap, and I know that you don't like it. No parent comes in and says, I want to yell just as much, but I want him to behave better.
Right,
They
right.
all want to yell less. So if you understand how the cycle again is coercive, then we can just get to work on it. So once we understand this, how do we break this cycle? And I don't know, maybe it's because I'm a parent, or I have always had a special empathy for how difficult it is. Now, I'm not suggesting that you don't, because
No, I know.
I, I I also have an empathy for couples, and I can't do that work.
Well, it's the same, right? I can't.
Yeah.
I have an empathy for couples, and it can be difficult work for sure. But I don't know. I have like a space where I can just dig deep, and I
Yeah.
just cannot with kids and parents. That's why I don't do that work.
Well, it's good to know your limitations, and
Yeah, I
we all have
can't.
them.
I've done it. I've done it a little bit before, and I'm not saying that I'm speaking from something that I've never experienced. Like, I have done that work, and I've tried very hard, but it is it. I don't know. And again, I'm a parent, and I take that very proudly, to my parenting my daughter with my wife. But it just, um, yeah, clinically, I don't know. It's a strange. It is always a strange thing where certain clinicians or psychologists can work with some groups and they just can't with others. Like,
Yeah.
give me the unmedicated person in an inpatient hospital with schizophrenia, or the sexual sadist and the pedophile any day before an 8-year-old with ADHD. I can't deal with it. I just can't do it. I don't know.
This might be one of the only practical applications in believing that free will is an illusion, because, which I do, I don't think it exists. And so then, no matter what behavior you're seeing in front of you, that person had no choice but
Yeah.
to be who they are and do what they do. And that helps me to,
See,
I'm not perfect, so obviously we all are judgmental sometimes, but that helps me.
I do the same thing, and I have done that with kids, and I just still can't push. I believe the same way you do, and I just can't push past it. I was like, well, I remember early on I knew this. I was one of my first rotations, and I was at an inpatient hospital, and I was doing assessment, and I happened to be on the children adolescent unit, and I'm doing the WACE. And I had a 6 or 7-year-old or something, or whisk, sorry, and a 6 or 7-year-old, and I get the blocks, and it was a block design is one of the subtests. I get one of a couple of the blocks thrown at my face, and which didn't bother me, but what bothered me was the running around the room and not complying, and this is like the third time I've been with this kid, and I'm just like, I remember I went to my supervisor and I said, I can't do it. I just can't do it. It's not for me. It's not for me. And I finished the case, but she would just like, she would laugh at me and she would just be like, yeah, that's not your population.
Yeah, imagine not being able to finish the case and having to go home to that sort of behavior every day.
Right.
Really hard. Yeah.
But, give me the adults that, have a whole host of other issues. So I can do that for hours and hours and hours. So it's so strange. Okay, so tell me about elimination disorders. Oh, wait, before we transition to that, I wanted to ask you this. I have to ask you this. So you had said it, I think, a little bit earlier, and I agree with you. But, and you don't have to give me like some kind of definitive, here's, your doctrine on this, but in so I don't look at disorders as a prescriptive thing, or I just don't, when I see people, I see disorders over their heads, I don't do that. They're a means to an end. I think they're very helpful they're essentially a type of heuristic of sorts. So I don't have to list every single thing out each time. I can just say, oh, that's bipolar too. But with in the new DSM, well, that's not new anymore. I guess it's, oh my goodness, 8 years old now. Wow. That's wild. So the latest version of the DSM, DSM-5, they added I'm going to get this wrong, disruptive mood dysregulation disorder. Did I get that right? And there's a little bit of controversy about it. Do you have any strong opinions about it, one way or the other?
I don't think so. I mean,
maybe we can say what it is first, and then you can tell me if you.
Oh, sure. So previous to that, when a kid was having high levels of noncompliance, aggressiveness, you had a couple of choices. One was oppositional defiant disorder, which is a milder of the two, and the other one is conduct disorder, which involves the deprivation of other people's rights more than oppositional defiant disorder does. Right. And some of those kids who have conduct disorder go on to become psychopaths, although it's a small percentage. And this is kind of related to what I was saying, is that clinicians were noticing that there were some kids who had a very strong mood component. So persistent irritability or meltdowns that would last for hours, and no amount of intervention or parental response could calm them down. And this is an example of how we take sort of the same group of people, and over time we start noticing differences, and that balloons into more disorders. So Alan Francis, who is a well-known psychiatrist, has talked about the danger of this, that, in 100 years, the DSM might be this thick. It started out like this. And is that actually helping us treat people better to further divide every single disorder?
And further pathologize people is essentially
right. Yeah, further pathologize the normal human experience. So totally normal for kids to flip out once in a while and roll around on the floor when they don't get what they want. Is there a danger that we're going to say that they have mental illness when they do that? And I think there is. So I think it's absolutely true that some kids have a very strong mood component in the oppositionality that they exhibit. And the fact that there's a new disorder may spur some, and it has really so far, spurred a little bit of work in trying to treat that differently when there's a mood component than for your calmer, non-compliant child. So there is some advantage there. So I think it's a mixed bag.
I wasn't a fan of it. I'm still not too much of a fan of it, for a variety of reasons. I don't deal with kids, so I don't have any skin in the game on this. But my reading of it is a little bit different. So DMDD fits under depressive disorders, and largely so. The new classification is mood disorders, and then you have two subcategories with mood disorders. You have depressive disorders and bipolar disorders. And the reason they wanted to make the difference is because they do somewhat look differently. I mean, we start doing hypomania, mania, cyclothymia, but they all subsume under mood. And if I remember correctly, DMDD is under depressive disorders. And which is,
I don't own a DSM-5, by the way, so I can't help you on that.
I have to know this. I teach this at another school, so I have to know this. And so my reading of it was there was essentially 4 disorders. So the DSM-4TR to the DSM-5 is the switch was from a axle system, so axis 1, 2, 3, 4, 5, to a more why am I blanking? Multidimensional fractal. So looking at things in terms of continuums or spectrums across the board, right? The biggest one was autism, but then they did that with schizophrenia, they did that with substance abuse, they did that with neurological issues. And so for this one, I thought it was the conduct and oppositional defiant, which fit under impulse control disorders, and then intermittent explosive disorder, which is also there, I believe. And then what was colloquially known in the clinical field as pediatric bipolar, because that was happening a lot. You would have basically pediatric is anyone under 18, so it's not necessarily infants, where you would have children that exhibited signs of mania, right? And they would say that for younger individuals, this was what they would call rapid cycling. And of course, adults have this as well, or can have this as well. And so they needed a new categorization. It was like, it's not intermittent explosive disorder, which is pretty extreme. We don't want to be calling kids bipolar. That doesn't sound good, doesn't look good. It's not conduct, because those are mini psychopaths. Again, it's kind of a colloquial way of saying it. And it doesn't meet criteria for ODD. It's like, well, what the hell do we do? So we need a new disorder. I think the problem I had with it was that there wasn't any, if I remember this right, I could be wrong on this, empirical data that they used. There was no studies looking at a new disorder. They basically imported studies from other disorders and then just made a new category, which I guess in theory you could do, but it didn't have, I think a large criticism, which I heard, was there wasn't a lot of empirical support for something distinctly on its own. It was more of a categorization. And so if you look at the criteria, it's really wild because it's like you have to be diagnosed, you have to have a first episode before age 10, but after age 6. So there's like this weird 4-year gap, 5-year gap where you have to have these symptoms, and they have to be the languages, angry outbursts. I don't have it all memorized. That are, there's a certain time period. I can't remember if it's a certain time 2 times per week or 3 times per month, and then another extremer version of that. There's like 2 subcategories with it of what the behaviors look like. And then of course it has to cause significant impairment, to social occupational functioning. And so it's just, I guess that for me, my biggest concern, the 2 concerns were the lack of empirical support for something this specific. They're just kind of importing from other things, which I can sort of see that. But then the big question the big point we just raised, which was, we're going to have, again, just for lack of a better word, we're going to have a bunch of bratty kids that are pathologized now, right? Just normal, disruption that kids have. Every kid acts out. Every kid is going to, scream and throw a tantrum every now and then. So we're supposed to say, look, now they have disruptive mood dysregulation disorder, and it's a mood disorder within the DSM. And now we get all these new cases of somebody that has quote unquote a mental illness or pathology.
Yeah.
That doesn't seem wise.
That's the worry. Yeah.
Those are some of my, criticisms of sorts.
Yeah, I'm not privy really to how the diagnosis came to be developed, so I'm not sure about the lack of evidence behind it. But I have not used that diagnosis very much in my career. I find that the existing ones usually do the job. Plus, I don't care about diagnosis very much. I care about underlying mechanisms that coercive cycle. That so much more important for me to identify that cycle between a parent and a child than to label a kid with ODD. Yeah. That doesn't tell me much.
Well, it's funny because most of the people that I know that don't care, maybe I'm just not as exposed to this, but most of the people I know that don't care about disorders and DSM are all the psychoanalytic people. But maybe that's something that you've held on to.
Yeah. Well, all the people who I know are really behaviorists because they care about learning histories and reinforcement and punishment and establishing operations and things like that. And they think that a label of a diagnosis is just unhelpful.
I didn't know that. That's a very funny convergence. I like it.
Yeah.
Okay. So tell me about elimination disorders. Maybe explain to listeners this very small category in the DSM, I think it is, and just what they are and what it looks like in terms of behavior, and then how you treat it. I'm sure we'll bring up Bell and Pad. That's what I know. That's like the extent of it. Tell us about it.
So small in that they're not that many disorders, but incredibly disruptive to families. So this is when kids are peeing and pooping in places that they're not supposed to, or And that can include diapers past a certain age and pull-ups and things like that. So some problem with eliminating of waste. And people usually say to me, "Well, what does psychology have to do with that? That sounds like a medical problem."
Right.
And I thought the same thing. And I remember attending a lecture in graduate school where my advisor was talking about these things, and I was pretty intrigued that a psychologist could play a role.
Yeah.
And it turns out that for many of these kids, there is a strong behavioral component, and we can really leverage our understanding of the way behavior works and then turn that into some effective treatments. And the treatments for elimination disorders from a psychological perspective are some of the most efficacious treatments that we have in the whole field of clinical psychology. So we're talking in the range of 80% either cure, which is not a word we use very often in our field, or dramatic improvements, significant improvements in these behaviors.
Is that because there's a somatic component to it? Is that why there's such a high effectiveness for it, do you think? Or I'll ask you generally, do you know why there's such a high efficacy and effectiveness, or any hypotheses about why?
I think one of the reasons is that the mechanisms that lead children to urinate when they're not supposed to and to defecate when they're not supposed to are not terribly complicated usually. So if we take encopresis, for example, which is the inappropriate defecation, the typical history of it is a kid has a painful bowel movement. And in the child of a brain, they think, well, that sucked. So what can I do about that? I know, I won't poop again. So then they withhold their poop, and there's only so much space for poop to go, although it's pretty incredible how much the intestines and colon can stretch.
Oh my goodness.
If you want to look at some wild photos, Google something called megacolon.
Oh my goodness.
And you won't believe how much poop a body can hold. And the problem is that the large intestine, one of its main jobs is to pull water from fecal matter. And so if you don't poop, the poop that's in there gets hard and dry and then gets stuck. But there's more poop coming. So what does that poop do? That goes around the impaction and it's undigested, and then it leaks out. And it looks like diarrhea, but the kid is incredibly constipated or what we call impacted. So the withholding aspect of it is something that fits very nicely into what psychologists do, because we deal a lot with repetitive behaviors that work in the short term, but are a really bad idea in the long term. And that's what withholding is. It does prevent you from feeling pain upon pooping, but it creates this problem that I just described. So maybe that's one reason that the model is actually pretty simple. And within uresis, which is urinating when you're not supposed to, the model there is also pretty simple, and it's typically an immaturity of the central nervous system, a lack of a learning history, and we can retrain people's brains to not pee in the bed or during the day. So where should we start?
So those are the two main disorders for elimination. Is there other ones? I can't remember.
Yeah, there are some other ones that affect adults mostly. So there's something called paluresis, which is called shy bladder syndrome. We all probably have a friend who won't pee in a public restroom.
Oh, yes.
And as you can imagine, super disruptive. I mean, you're either going to be in horrible pain or you're not going to leave the house very much. But those are the two main elimination disorders when we're talking about kids.
So I'll just start in one way. Is some variant or version, kind of what we were talking about with like phobias and social anxiety, I guess, with elimination disorders, is the gold standard some form of behaviorism, behavioral interventions and treatments?
The gold standard is a combination of a medical approach and a psychological approach. So we call it the medical behavioral treatment of encopresis. And so it might make sense if I sort of chop the treatment up into its stages. So the first step is a clean out. Well, let me put it this way: when there is withholding of poop, which is not 100% of the time, but probably 85 to 90% of the time, these kids are backed up in withholding poop. So when that's the case, the first step is a clean out of the large intestine. And if you've ever had a colonoscopy, and you remember the day before, which is the worst part of a colonoscopy, is drinking that stuff and
I've never
very
had
high
one,
doses.
but I've heard stories.
Not pleasant.
Yeah, I've
So
heard
very
stories.
high doses of laxatives
Yeah.
to totally clean out your system, and that's what we do with kids. And we can get into it, but it's basically like a horse dose of laxative. It is. It's hard to believe how much we use. And a psychologist can actually direct this. This is all over the counter stuff. You don't have to go to a gastroenterologist to do this, and that surprises some people. So once we get it all out, which can take a couple of days of just hanging out by the bathroom because you're going to be running to the bathroom constantly.
Yeah.
So now the colon is cleaned out, but we still have the consequences of withholding. And what that sometimes can mean is that your colon is stretched out. So what happens when it's stretched out? Well, two things happen. One is that it now holds a lot more poop than it used to. So you're at very high risk for, once again, that bag being filled up with fecal matter. And the other is that you lose sensitivity in the nerve endings that are in the colon. And which means that you can't tell that you have to poop. And so we are trying to let that colon come back to its regular size. And unfortunately, that can take a year sometimes. Wow. So we are sort of at increased risk of this reoccurring for quite a while. So once we clean all that out, then we start what are called scheduled toilet sits. And this is really where a good behavioral psychologist will shine, because these kids don't want to sit on the toilet 3 times a day for 15 minutes at a pop. They will say, I don't have to go. I don't feel anything.
Right.
Which in part is because the nerve endings are sort of deadened. Plus, it's boring. So you throw in maybe a kid with ADHD. Yeah. He does not want to sit on the toilet. And so they will refuse. They will run away. They will. Then we get the escalation happen. And so that's where we use a lot of our parenting techniques. So my expertise in parenting and in elimination disorders is a really good mix here.
Would you use something like for like these kind of sits? Would you use something like my first pull is, well, maybe something like a token economy system, right? If you sit for 15 minutes 3 times a day, every single day for the whole week, you get X, a Snickers or something, I don't know, or you get some small toy you wanted, I don't know, whatever, depending on the age of the kid. But there's some kind of token system. You get 3 gold stars, and then now you have
absolutely
whatever, something like that.
Yeah, and so that sounds like it might be a pretty easy thing to come up with, but there are a lot of roadblocks to an effective reinforcement system. One of which is that parents often save the reinforcement for like the end of the week. And if you are trying to reinforce a new or a difficult behavior, that is not going to cut it. There needs to be reinforcement happening right now, and then maybe also at the end of the week.
Right.
So, yeah, there's another pitfall that I see a lot. I'm on some of these Facebook encopresis groups, and if you want to like feel heartbroken, go on those to see the effect that this has on families. It is just, and it can last for years before people get appropriate treatment. So if you think about it from the child's perspective, the social costs of having an accident at school.
Oh, the amount of shame! My goodness.
Takes one time for you to be labeled as that kid.
Oh yeah.
So I was just talking about this with some of the parents. Is they will often give an iPad to a kid to sit, um, and then and this is one of the things that you don't think about unless you do this a lot. But when the sit is over, they'll take the iPad back. So what does that do from a kid's perspective? And I always like to put myself in his shoes. What would I do in that situation? If it were me, I would try to stay on the toilet as long as possible, and that means I would try to withhold my poop as long as possible. Because once I poop, what if my mom comes in and says, "Oh, you pooped, you're done. Now give me the iPad." So inadvertent training actually can happen of more withholding of poop. These are the things that, unless you did this a lot, you wouldn't notice. And that's why a psychologist can play an important role. Okay, so now we have daily sits where we're pooping on a regular basis. The large intestine is healing. Then we start to taper down the laxatives. And we also work on exercise because a lot of kids are sedentary, and aerobic exercise produces motility, which is the fancy word for movement of poop. We work on water intake. We work on fiber intake. A lot of kids eat really low dietary fiber diets. The parents will say, he'll eat three things: chicken nuggets, macaroni and cheese, and pizza.
Yeah,
and there's almost no fiber.
No fiber there.
So we use some of our very gradual behavioral techniques to slowly introduce some fiber, and it might be 5% whole wheat spaghetti and 95% of your typical spaghetti, but it's got to be the same color, or the kid will notice this is not normal, and those sorts of things. And then there's the, like, it can expand outside of the behavior of pooping. There's the tantrums, the non-compliance. So it can be very focused, and we're talking like 85 to 95% effective when we do that, and it can also expand to more general parenting work.
And so, what about enuresis? So urination, and is there a distinction between? Again, kind of I'm always thinking about this stuff. Is there a distinction between age appropriate, normal, wetting the bed, when you're trying to sleep through the night, and you've got what do they call those? It's been a long time since I had these. The
pull-ups.
Yes, thank you. The pull-ups, and maybe they take them off, and they're still there's kind of the normal, quote unquote, normal cycle that a kid goes through developmentally, and then they eventually figure it out, and then they're fine. And then there isn't, or can that happen concurrently? So, like, let's say I'm trying to think of the ages here. The 3-year-olds, is there like the 3-year-old that just does like the normal bedwetting because he's trying to learn, and then there's the 3-year-old that has actual enuresis? How does that look? I'll let you answer that one. I have a few other ones.
Yeah. Well, we can't actually diagnose enuresis until age 4.
Okay.
So it's considered normative to be wetting the bed until that age. But see, so that's an example of a arbitrary cutoff on a continuous variable. So if we go back to how does this issue impact your functioning, that's a much more important question. So I've had 6-year-olds who are peeing in the bed most nights, has literally no effect on anything that they do. Even can go on sleepovers, can go to camp. But then there are 4-year-olds where it really does impact. The preschool won't let them enroll unless they are fully toilet trained. So we focus on functioning, and unfortunately both problems can occur at the same time. So when a kid is impacted, that fecal matter can push onto the bladder and reduce what we call the functional capacity of the bladder, so that they just can't hold much urine. And then they're having accidents where the cause is the encopresis. So the benefit of that is if you can successfully treat the encopresis, the enuresis, the urination problem can improve.
Is there a comorbidity between enuresis and encopresis?
There is. And when both things occur, I always work on the encopresis first because it's usually more disruptive. and it also can fix the enuresis.
Huh. I didn't know that.
Yeah.
Wow.
Should we talk about treatments for enuresis?
Yeah, I was gonna say the one I know. I mean, this is Bellin Pad. Did I get that right?
Bellin Pad. That's the gold standard.
That's the gold. Is that still used? It's still the gold
Absolutely.
standard. Okay.
Yeah. It's not easy because what it is a moisture alarm, and as soon as any moisture is produced, a big alarm goes off and wakes everybody up in the house. And it has to be a big alarm because a lot of these kids are really deep sleepers.
Yeah.
And they will sleep right through your typical alarm. So even though it's highly effective, it is a tough few weeks for everybody involved.
So sorry, the basic function of it is basically there's a pad that you put on the bed before the child goes to sleep.
Or in the underwear, right in the underwear.
Excuse me, yes. And then they have that there. And then as soon as there is any amount of liquid, the big alarm goes off and then it says, okay, you basically got to go to use the toilet.
Yeah, exactly. So they're able to stop midstream the accident and finish off urinating in the toilet.
Right. And this has a 80 to 85% succession rate. Is that right? Something like that?
When done with fidelity, which means if you do exactly what you're supposed to in the manual,
right.
But the manual doesn't take into account that maybe you live in an apartment complex where your neighbors are not going to be too happy about an alarm going off all night long for weeks.
Right. Yeah.
So in theory, yes, 85%.
Other treatments for enuresis?
Yeah, there are others. So the safest thing to do is just wait, but only 16% of cases when you examine them a year later have resolved themselves. So most kids a year later are still going to have it.
Yeah.
There are a few treatments that have less research support, but still some. So Kegel exercises, for example, have shown some efficacy. Just straight reinforcement, like you make it through the night, you get a fairly sizable reinforcer can be useful. And by the way, all of these can be used together to kind of supercharge your results. Most parents will try to reduce liquids at night, which is not going to really fix the problem. It may reduce the size of the accidents. What we actually do once the Bellin Pad has started to work is we increase liquids at night. So we have kids chug water before they go to sleep so that they have actually more accidents during the night and more learning trials of that alarm going off. So that's a pretty interesting, I think, maybe non-obvious way that a psychologist.
It seems counterintuitive, but as soon as you started telling me, I'm like, oh, I get it. You want the habit to form, right? Where it's like, oh, boom, okay, now I have to go and do this. So that makes sense.
And then there's diurnal enuresis. So when accidents happen during the day, that's more complicated. There can be lots of reasons for that. There could be an anxiety component. So some kids will not pee at school. They will only pee at home. Even in extreme cases, OCD can be the cause of that. And the main way that we treat that is with scheduled urine sits. And that can be every hour.
Yeah, I think the one I definitely think with something like that is the social component, the different types of social emotions that come into play here is tricky. And I'm not well studied on this stuff. There's a myth, maybe it's not a myth, but you tell me, that if there are certain folks that have bedwetting, that there's some a connection with some type of sexual abuse. Have you heard this?
I have a lot.
How is that garbage? Is that true? What is the evidence on that?
Yeah. So we distinguish between two kinds of elimination disorders: primary and secondary. Primary is when someone has not had continence at all. So every baby has primary problems, whereas a secondary enuresis or encopresis is when they've been fine, for at least, I think the criterion is for 6 months, and then they start having this problem. So I'm not aware of any evidence at all that primary enuresis or encopresis, where they've never had continence, is associated with sexual abuse. There are some not well done studies, because you can't randomize people to be sexually abused, that secondary enuresis and encopresis is associated with abuse. But I will tell you that clinicians vastly overestimate this as a cause. It's almost always just a much simpler explanation, like a painful bowel movement. There's 100 of those for every sexual abuse.
Yeah. Okay. Yeah, because I've heard some clinicians, again, I don't know this stuff, but they'll be like, oh yeah, some people that in the trauma world, they're like, oh, they're bedwetting, they were sexually traumatized. I'm like, whoa, wait a minute. I don't think that's a one-to-one thing there. I don't know if that's how that is.
This is a bigger problem I have with our field, is that we tend to have an aversion to Occam's razor, to simple answers. We love complicated, multifaceted answers to everything, where students will applaud you once you finished, whereas it's kind of boring to say, "I probably hurt when he pooped, so that's why he's not pooping."
Right.
You don't get applause for that.
Right. Okay. So anything else you want to close the loop on that topic? I think we talked about what it is, the treatments. Anything else you want to say on that particularly?
There are just very few psychologists who know how to treat this, and who are not scared of talking about poop. There's not a great way to find them, unfortunately. I remember there's a great website of psychological referrals, and I remember a few years ago looking in New York State, and there were 3 people who listed encopresis as a specialty, and I was one of them. People can look my website up, and I have some information there on referrals and how these problems develop. But it's super frustrating, and it's just so easily fixed if you get the right treatment. So I've made it a little bit of a mission to make a dent here.
No, that's great. Okay, so it's one of those things, right? Sometimes it's funny when you get a guest on, and they're a specialist, and they might do 1 or 2 things, but you can just really drill down very quickly on some of that, and then it's 2 or 3 hours, and you're like, whoa, it's super quick. But I also am mindful that people have their areas of focus, but then they have other things they're interested in and other things they like as well, and so maybe we can just here at the end here just spend a little bit on other things that you're passionate about, other things you're interested in, other things that you really get you going. Anything in particular you want to start with? I have a few, but anything you want to start with?
Do they have to be psychology related, or
no, whatever. Yeah, I know we've talked about some of this stuff in academia, some of the free speech stuff.
Very interested in free speech, and it ties into my interest in discomfort and helicopter parenting and that sort of thing. And if people are interested in this, the coddling of the American mind is probably the place to start.
It's a great book.
So I work with an organization called Let Grow, and it's headed by a woman named Lenore Skenazy, and they work with schools to basically assign students homework to do things without a parent standing over their shoulder. I am very passionate about kids' independence, and anytime I talk to a parent about their childhood, they say, "Oh yeah, I used to be able to do all this stuff, and I got all these benefits from it, and it was amazing." And then I say, "So what do you let your kids do?" "Oh no, they can't do that stuff." Even though objectively we live in a far safer world,
society, right? It's much safer.
Cell phones and all that stuff, and I won't get into that. But kids' independence is something that I'm really interested in, and I'm thinking about how we can use independence activities actually as a psychological treatment for anxiety. And experimenting a little bit with doing that. And I think it's an area that my field has not spent enough time on. How to encourage independence, and could that have pretty significant mental health benefits
Mm.
for kids?
No, that's great. Yeah, I totally agree. I think yeah, John Haidt kind of was promoting this, let grow, and then I've
Hmm.
seen it other places on other people, and I think it's great. I think that obviously you want to be mindful and smart about things, but I think yeah, this kind of the colloquial helicopter parent is very harmful, inadvertently so, right? I think parents,
Inadvertently,
yeah,
best best intention.
care about their kids. They want their well-being. They want them to be safe. They want them to, but there's, um, we need, I see, I see kids. So let me clarify something I said earlier. So I don't work with kids clinically, right? I do like kids, right? Kids are great. Adolescents are great. Just clinically, it's just not my forte. Um, but all the time with my own daughter, and then with her friends at different stages, and other nephews and nieces and stuff. I always see children as just little people, just growing, developing little people. And so I try not to, talk down to them or talk to them differently, or, like their opinion or value, or don't have, their opinions don't have merit or value. And so
I think kids really appreciate that.
you want to try and understand what's their
Yeah,
perspective. And in
yeah.
fact, it's the opposite for me. It's more of, man, I don't have that perspective anymore where everything's new, everything's fresh, everything is so, I don't want to say innocent, but you can use that, I guess. But there's this like kind of fresh perspective. Like I don't have that. I've lived in the world enough. I'm jaded in some
Hmm.
ways and other, so it's like there's a type of nice quality to that. And that's always curious for me. Kids always ask good questions, I think, and so yeah, I think part of the let grow thing is important because it says, hey, how can we foster that? How can we push for that? For kids to develop a sense of independence and autonomy, and to find their way.
And
And
there's so many ways to do it. I was at a party. I guess it's now more than a year ago. That was the last time I was at a party, and I saw I saw this. I think she was probably about two, little girl struggling to get her sweater off, and it was like, how it gets stuck in your head and you're trying to pull it off,
right, right,
and the mom ran right over to pull it off, and nobody else but a child psychologist would notice that. And so I thought, well, what would have happened if she let her struggle a little more? Could that actually have been one of these micro doses
yeah,
of discomfort, of resilience, of figuring it out? But we're very quick to interfere with these situations, and they happen all day long. So that's another area where I'm interested in. What if we dial back a little bit in what we do and we let kids struggle a little bit? Could that be really good for them, actually?
yeah, 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 yeah. I fully agree and support that. The kind of rule in my house is my daughter will have some uh, question or some difficulty with something, maybe some social kind of challenge, friend groups, some drama or something.
Hmm.
And she'll ask me, and she'll tell me the whole thing, and okay, and or we'll read about something, and she'll tell me, tell me the details, and then sometimes she doesn't do this anymore, but because I've conditioned her very well, but she'll say, okay, what do you think? Nope. Nope, you don't
Yep.
get my thoughts. You don't get my
Right.
thoughts. Not yet. And so I was like, "What do you think? Just what's your impression?" And then I kind of the same thing I said earlier is I don't have that. Like I've read this, or I've seen this, or I've heard this. Like, I have ideas about what I think about it, but I'm not hearing it the first time. What do you think about this? And so she'll say, well, I don't know. And then she'll start thinking out loud, and this, but this, and this, and this.
Yeah.
And it's like, yeah, that's
Such
right.
a favor you do for her to make her do that little bit of work.
Yeah, both my wife and I both do that, and so it's I think it's great. So now she's kind of just comes to things in that way, and so then sometimes she'll tell me, and then I'll say okay, and I said, well, do you want to hear my opinion? She goes, no, that's fine. I just want to talk it out. I'm like, well, I want to share my opinion. Maybe let me share my opinion a little bit, right? And so I tease her a little bit, but um, yeah. So I think in certain ways, I think doing that with kids is important to see what their ideas are, what their perspectives are, and they're growing people. They're little people, but they're growing people, developing people, and I think as a society, if we do that, it's much better than trying to indoctrinate them with, whatever uh, system you think is right. I mean, that's not to say that there shouldn't be, um, framing, that there shouldn't be some type of systems or rules that are, that kids should learn. But I think that there should be some um, flexibility with that, and not always trying to jump in, and help them take the sweater off, right?
Yeah, yeah. I
um,
saw some statistic that padded playgrounds have higher accident or injury rates than unpadded playgrounds, and I think that really says it all. Kids have to learn how to manage danger, and it makes them unable to do that if they don't face it.
in I think the last year of elementary school, my daughter, was telling us some of these rules about things, and we got the manual. And I'm not one of those parents that tries to make administration or teachers' lives more difficult, but and there's things I'll kind of look at and I'll just kind of roll my eyes and be like, whatever.
Let me guess. No tree climbing.
No, it was close. It was no tag. You couldn't play tag. Couldn't play tag. And I was like, what? And I look in the manual thing they give us, and I'm like, oh, you gotta be fucking kidding me. Are you serious? And it's just
Because
like,
it's
yeah,
physically
because it's
dangerous, or
yes, because
because
it's yes,
it's hurtful if you can't catch somebody,
it's
and
physically dangerous.
emotionally hurtful.
No,
Okay.
not quite that, but it was the physicality of it. If you're running, somebody falls, or somebody hits someone too hard when they tag them, they don't want. So they didn't have padded playgrounds, but they definitely were doing a lot of quote unquote child proofing. And you know, I didn't make a thing of it because it was, I think, the last year, and I was like, whatever, you're done there. You're gonna move off to middle school. Like, it's
Mhm.
not a big deal. But it was a strange thing, and I was like, this is preposterous. Like, is
Oh,
this?
that's even worse than no climbing trees.
It is worse than climbing on trees, right? 'Cause it's on the ground, right?
We
Like
are
it's
constructed to play tag and climb trees. Every other primate in the
well,
world
I
does
was
the
gonna I
same.
was gonna go up there and if I was younger, I probably would have. But as I get older, I'm like, it's not worth it. But there are other battles that are worth it. But I could have gone over there with tons of literature and full blown Piaget of different types of play are important for cognitive
Yeah,
development, you idiots. But
but they're
but
also
I didn't do that.
well-meaning. They're
Yeah.
also
No, this
well-meaning.
well intentioned, and then that was my thing. I was like, they're dealing with a lot of different kids, and they're dealing with a lot of different things, and I was trying to be understanding, but me, and then my daughter was the one who's rolling her eyes the whole time. It's just like, oh gosh, and then she told me something really smart. She goes, yeah, now everyone's going to play tag because you said we can't. She's like, I'm not, but everyone else is going to do it. I'm like, right, right,
Yeah, yeah,
right.
yeah.
Um, so yeah, just the last thing I don't always ask this for everybody, but you you had mentioned that you're uh Hispanic, yeah?
I am.
Yeah. So just tell us this a little bit, just briefly. You're Colombian, is this
Clear.
correct?
I'm Colombian. Yeah,
Yeah, so you were born in Colombia, or you were born here,
I
or
was born in
yeah.
Colombia.
And
For
I think
many
that
generations, Colombians. People
oh
think, well,
really?
you were born there, but your dad was on business. No, fully Colombian for
Yeah,
many
yeah.
generations.
And do you care about that stuff, about identity and culture and how you identify, or it's just like, whatever, it's just the cards I was dealt? Or how does it integrate, I guess, into you personally, or your work, or things like that? Do people come to see you as a Spanish speaking psychologist that can help, and carry yourself that way? Or it's just kind of a, it's a part of me, cards I'm dealt, I don't emphasize it? How do you put that in the mix?
Well, we could probably have another podcast just on that question.
Yeah, no,
Um,
just the Cliff Notes version.
the Cliff Notes. Well, I mean, I don't think I can separate the fact that I'm Colombian from the fact that I'm also an immigrant. And so when you're a kid and you're an immigrant and also grew up quite poor, then all of that is intertwined, and kids don't like to feel different. And so I remember I once told my mom that I wanted to change my name and that my new name would be George, because George sounded American and I really wanted to be American because I was 5. And I the person, she still has a neighbor who thinks my name is George, and I haven't lived there in 35 years. So I love being Colombian. It's an important part of my identity. Um, I guess when I was younger, I viewed it as a liability because it made me different than other people.
Mm.
But I really love that wrinkle about me, especially because I also don't look like the stereotypical Colombian, and so I love the confusion that people feel, and I love talking about it. So
Mm.
I'll get very often. So where are you from? Where's that name come from? And I guess I could treat that as a microaggression, but I actually treat it as an opportunity to form a connection and to
Right.
talk about my roots. And many people are surprised that there are people with white skin who live in South America, just as people came over to the United States who had white skin. They also went to other countries down there. So I don't know. Is that the Cliff Notes version?
Yeah,
Yeah, I guess so.
and I mean, you're immigrant, so you're not first generation or second generation, and how does that for you? How do you, your sense of, this is probably a bigger question, but just again, a short version of how you acculturate into the United States culture and things like that. Is it again not drawing lines, but just in terms of identity and how you, I guess, integrate? Is it like I'm Colombian American, or I'm both, or you don't really care, or how do you see it that way? I guess.
Yeah, I don't think I use a label very much, but I think the
Hmm.
Colombian American label fits me well. I
Hmm.
mean, Spanish was my first language. I was born there. I only speak Spanish really to my family. Um, but I'm certainly American, and I really like this country, love this country a lot, and I feel very fortunate to live here. And I thank my mom for making that difficult decision of showing up at JFK Airport with a 2-year-old and $50 in her pocket,
Yeah.
and somehow managing to make a life here. So uh, I I'm a big fan of immigrants, and I think they're resilient, brave people, and I think we need more of them.
Yeah, yeah, I agree. I've said it a bunch here, so I won't belabor it. But my dad immigrated here from El Salvador, and very much the same. I mean, he lived here for a long time now, and so he's um, yeah. I mean, he sees himself as both. He's very proud to be an American. He's like, but I'm obviously Hispanic, and um, kind of the same. He loves this country. He's very proud of it. He's likes immigrants. He likes people coming here, and mostly if it's a way of you're making a better life for yourself. So use that. Don't squander that. Um,
For sure.
and yeah, I mean, so I was born here, so my mom's white, so I'm half, but I I also feel the same of I love my country. I'm proud of where I'm from, but I'm also proud of both sides of things. Of my ethnicity and race, and so I think once you start with the individual and then you move outside of it, I think it's a really wonderful variable to consider about someone's experience and who they are, and I think there's a helpful wrinkle there for the world of clinical psych and having people from different places and perspectives and backgrounds to not that you just get it on uh like, oh well, you're Latin, so all these things, but that the particular person is, they're this individual, but then they have these other elements to them. I think that's important, as well for our field, and I think that's yeah, it's even though I'm American and half white. I also am half Latin, equally both, and so I am proud of both. And so I will occasionally, from time to time, talk about it. So,
cool. Yeah, nice to hear your experience as well.
Yeah. Okay, man. You've been generous with your time. Tell folks where they can find you, and you could get any of your materials or your stuff, or best ways to contact you if they want to. Yeah, what are the ways to find you?
Yeah, probably the easiest way is my website. So it's Dr. just the two letters, Dr. Camilo Ortiz.com. So just one L in Camilo. And I have videos on there for parents and for people, adults suffering with anxiety and things like that. I think try to make that website really useful, and they can follow me on Twitter if they want a little more than the psychology aspect of me.
That's great. Well, look, I greatly appreciate you coming on. You've been, again, really, really helpful for me and hopefully for listeners, and telling us about a lot of things. So you're a good guy to talk to. So you're always welcome to come and talk to me anytime. Thanks
so much. I really appreciate you giving me the opportunity to talk about some things that are important to me. It was a lot of fun.
Of course. Same. All right. Thank you.
All right. You got it.